some patience, as this is a large agenda and I've yet to chair a WETU meeting. So I think it was a goodbye gift from Gary for me. So call the meeting to order, and just looking for a motion to approve the agenda. Moved by Aldo, seconded by Ed. Anybody opposed? Seeing none, that passes. Any announcements of conflict of interest at all? If you're on the phone, just speak up, but seeing none, moving on. So just looking for a motion for the approval of the minutes from August 11th. Moved by Judy, seconded by Tracy. Anybody opposed? See none, that passes. Thank you. So business arising, we'll go to Lori for 6.1 for the charitable status report.
Thank you, Reno. So as a follow-up to the question that was asked of administration in July of 2022, when we brought our report forward for applying for charitable status, administration investigated the number of public health units in Ontario that had such status. We're reporting back that of the 34 public health units in Ontario, we have 10 that are registered as charities, all of which had effective dates for charitable status of prior to 2012. In 2012, there were amendments to the Income Tax Act that allowed municipalities and municipal and public bodies performing the function of government in Canada to apply for what is called the qualified donee status. The status is effectively similar to that of a charitable status in that you're able to issue official donation receipts to receive gifts and register gifts from registered charities, and you have the ability to apply for rebates. For example, as we discussed in July, charitable tax rebate on property taxes would provide for a 40% rebate on taxes. In addition, it would allow us the opportunity to access grant opportunities. So of the 34 public health units in Ontario, there is one public health unit that has such status, and that is the Southwest Public Health Unit. Additionally, the health unit looked to other local entities, public sector entities, to see who would have such status, the qualified donee status in Windsor and Essex County. We identified the City of Windsor, County of Essex, the townships of Essex, LaSalle, Leamington, Lakeshore, Tecumseh, Amherstburg, and Peely, Caldwell First Nation, the Windsor-Essex Community Housing Corporation, and the John McGivney Children's Center School Authority. All of these entities do have that qualified donee status. As a follow-up, we have drafted a letter to apply for the status to the Canada Revenue Agency, and that letter has now been submitted and would wait for review and final decision by Canada Revenue Agency. Thank you.
Thank you. Any questions at all for Lori? I don't know if I saw Nicole had her hand up earlier. Did you have anything to add, or?
No, just noting that we skipped 4.0.
Thank you. I just wanted to make Dr. Nezateri wait a little while. So can I just get a quick motion to receive Lori's update, please? Moved by Judy. Or Judy, do you have a question? No. Moved by Judy, seconded by Aldo. Anybody opposed? Seeing none, that passes. We'll go back to 4.0 for a COVID-19 update. I think I just subconsciously wanted to be done with COVID, but we'll go to Dr. Nezateri for our COVID update.
Board Chair, Mr. Borlin, members of the Board of Health, my colleagues, thank you for allowing me to speak today. And I do appreciate the opportunity to share my perspective on COVID, but on also other related items. First of all, I think that we have to learn to and I'm looking at my notes to the left here because I'm going to talk about a few numbers. First of all, I think we have to accept that we have to normalize our life with COVID. But normalizing our life doesn't mean that we ignore its impact or its burden. We in Windsor-Essex have had 663 deaths since the beginning of the pandemic. In the past week, we had 6 deaths. And of those 6 deaths, 4 people were living in the community. So COVID affects people who are both living in institutions such as nursing homes and retirement homes, but the deaths are also in people who are living in the community. At this point in time, we have a bivalent vaccine, and that bivalent vaccine is available. The initial focus is on getting the vaccine out to the highest risk populations, but as the weeks progress, the vaccine will be available for everyone who wants the vaccine. At the current time, there are approximately 250,000 people who are eligible for the vaccine who have currently not been vaccinated. It's a staggering number, 250,000 people. And I think it's important that we encourage people to get vaccinated. Stated that in another way, it's about 16% of the population are currently up to date on their vaccines. So my message is twofold on it as it relates to vaccines. One is, if you're eligible to get up to date, please get up to date. When you get vaccinated, you're helping yourself and you're also helping some other people. In general, people that are not sick are less likely to transmit any infectious disease or respiratory-based infectious disease to somebody else. So when you get vaccinated, you're less likely to get seriously ill, you're less likely to die, you're less likely to be hospitalized. And when one person gets vaccinated, they're also helping other people in their household and people across town and people that they don't know. Secondly, I would ask for everyone to recognize there are multiple distribution channels for the vaccine. And those distribution channels are pharmacies, physicians' offices, clinics, and the public health service. Up to this point in the pandemic, my colleague had mentioned that 64% of vaccinations in Windsor-Essex had been done by the public health service. That's not sustainable because we have a lot of other priorities, and we really need, and Christy would correct me if that's the wrong number, but we really need physicians' offices and pharmacies and other traditional distribution channels, just like the flu, to get vaccine out to people who are eligible. If I could just briefly switch to, I think, perhaps something that we can take some joy, if I could use that word, is the vaccine verification process. Vaccines are probably one of the most effective treatments we have in medicine and are particularly effective in public health practice. My mother remembers polio. I've not treated a case of polio. And we vaccinate people against polio. In Ontario, there's a very progressive piece of legislation. It's called the Immunization for School Pupils Act, and it provides a framework by which we can ensure that young people are vaccinated. It is a vaccine verification process, but as a result of that, it results in people becoming up to date for vaccines. This year, and this recently, we had 19,000 young people between the ages of 12, in grades 10, 11, and 12 in the health district. And as of today, I think about 18,000 have come up to date. It's been a lot of work on the part of the public health service, but really the benefit here is just not the young people being vaccinated today, which is a clear benefit, but there are other benefits from the public health. When these young people leave high school, they'll have an opportunity to be up to date on their vaccines. And that is something that's positive. I would almost call it a gift, that when we have young people leave high school, that they're up to date on their vaccines. And the vaccine verification process highlights the fact that there's certain vaccines that are not part of the Immunization for School Pupils Act, but people do have an opportunity to avail themselves to those vaccines as well. And I think that's a positive for the public health service and for the Board of Health and the community overall. With that, thank you so much for allowing me to speak. And I know Christy will supplement my comments as it relates to the vaccine verification process, but I'm happy to answer any questions.
Thank you, Dr. Nazatheri. Questions, Councillor Sneeman? You're muted, Counselor. You're muted, Counselor.
Can you hear me better? Okay, thank
There
you. Doctor, for those, including myself, we have the 4th shot. Do we have anything newer now, right now, or are we still talking about the 4th shot?
Well, the bivalent vaccine is eligible for a number of people. I don't, because this is a public meeting, and I don't want to talk about your individual health, but
Like me.
If you've had, there are many people, 250,000 people who would benefit from the vaccine. I don't want to comment specifically about your health status, but if you call me privately, I'm happy to chat about it. But there are many people who are eligible for that 4th shot, who've had the primary series, meaning the first 2 injections, that may have had a 3rd injection, and now are in the eligible time period, which is 6 months after that 3rd injection to get a 4th injection. And if you are eligible for it, then I would recommend that you get the bivalent vaccine, which is currently available. But as it relates to you personally, just call me and I'm happy to chat about that as well.
Okay, thank you, doctor.
Thank you. Any other questions, Nicole?
If it's agreeable to you, Mr. Chair, I would just wondered, Christie's on the agenda under new business to talk about the bivalent from an operational perspective, and I just wonder if now is a better time for her to address that, and then may answer some of the questions for him.
Sure. So we'll just move to 9.1 and we'll go to Christy for that.
Thank you. So we do have, Councillor Sleeman, hopefully this will answer your question, but we do have bivalent doses of vaccine available here in Windsor-Essex. As a part of the provincial rollout, the bivalent Moderna vaccine, which is the one that's currently available, is open to 6 priority groups. Those individuals are 70 plus. They are pregnant individuals, healthcare workers, individuals who are First Nations Inuit Métis 18 plus and 18 plus household members, individuals who reside in long-term care home retirement homes, including long-term care home retirement home staff and 1 essential caregiver. And I'm missing 1 more, and pregnant individuals. So those groups all have ready access at this time to the bivalent doses. Anyone is eligible, anyone is able to get a bivalent as long as they have had a primary series. And the recommendation is 6 months after your last dose. So individuals who meet one of these priority groupings, as long as their last dose was at least 3 months ago with a recommendation of a 6 month, then they're eligible for this bivalent. So it could be a 3rd dose, it could be a 4th dose, it could be a 5th dose in some cases, depending on that time frame. So currently we do have a limited supply. Our focus right now is certainly our high-risk congregate living facilities, so such as our long-term care retirement homes, as well as shelter populations, supportive housing, et cetera. So our mobile team efforts are certainly focused there. We are running appointment-based clinics for access to the bivalent for these priority groups. So we do have those on an ongoing basis. Our website will continue to be updated, and we'll have clinics continuing into next week, and also working with some of our high priority community partners to bring vaccine access into some of those high priority community and high risk FSAs that we have here in Windsor-Essex. So starting the week of the 26th of September is when it's expected that the province will open up eligibility to all individuals that are 18 plus in Ontario to access to bivalent. And so the recommendations around that 6 month time period with a minimum of 3, that will apply to everyone. The other age group that continues to see increased access is the individuals who are 6 months to 5 years of age. We do expect information and an updated vaccine recommendation statement for the newly approved infant pediatric Pfizer vaccine. And so that will be coming into our community as well for next week. Starting the week of the 26th, the health unit will continue to support not only mobile strategies, but also continue to support clinics. We're going to be opening up an outdoor tented clinic here at our Windsor office on Olette, as well as, again, working with partners and certainly working towards additional mass or mid-mass vaccination sites as demand comes up once we see that increased eligibility. I did leave off 1 priority group, which is individuals who are immunocompromised, ages 12 plus. So that I apologize, I missed that in my initial rollout of those 6 priority groups. Those groups will continue to have priority access for the remainder of next week as well. So that's, we are starting to see pharmacies in our area. There's 20 pharmacies that now have bivalent vaccine, and they're also rolling it out to priority groups. And certainly we're supporting any access to primary care that are interested in vaccinating clients from these priority groups for the next couple of weeks. So certainly more to come. I think things will continue to change. Expect more ready access. There has been a delay, it looks like, in the Pfizer bivalent approval. I think we were expecting that to potentially be for the week of the 26th, but it looks like there's going to be some additional time there. So certainly the current bivalent vaccine, the Moderna Spikevax, will continue to be the one with the most ready access here. Happy to take any questions.
Thanks, Christy. Judy, questions?
Hi, thanks. So a couple questions. Confirming bivalent is the name of the new vaccine that treats the updated Omicron variants?
That's correct. It treats Omicron variants 1 and 2.
Okay. And so when we're saying 3 months to 6 months for people to get, so some people were just eligible in July or August and got a 4th vaccine of the first set. So are we recommending to the average person they wait 6 months from that shot, or they can get it as soon as 3 months if the supply is available?
Yeah, so
Thank
what
you
you said is exactly right. The recommendation is 6 months, but individuals are able to after 3.
Thank you.
Thank you. Any other questions at this time? Seeing none, so I'll just look for a motion to receive the update for 9.1. Moved by Joe, seconded by Judy. Anybody opposed to the motion? Seeing none, that passes. Thank you. So we'll go back to 6.2, which is the Board of Health Bylaws and Policies. Just look to Nicole.
Yep. So I know there is not a red line on some of these bylaws and policies. This is the last of, we've been bringing these since I think we first started maybe in April of this year. And this is really the remainder. Obviously, the format of the bylaws have been changed as per the direction we received early on. So previously, our bylaws were one giant document of about 170 pages. This substantially breaks them down into, instead of one, we now have 4. So you have before you the governance policy, the finance policy, human resources, and the management of real property. As well, as we discussed early on in our previous bylaws, consolidated bylaws and policies, there were a number of what would really be policies included in the bylaw. And so we've done our best to, the substantial changes that have been made to the bylaws are anywhere where language is outdated or need to be updated. So for example, just reference to the Ontario Public Health Standards, previous version, so 2018, now it's 2021. So just basic updates like that. I know Lori has already spoken to the finance policy updates and some of the changes just as it relates to certain legislation. And so updating relative to that. There's no other substantial changes other than we probably had about 40 pages of references in our previous bylaws. So those have been removed. And then again, the policies are really items that were previously in the bylaw itself that we've moved now into a policy document. So for example, 6.2.3, performance of the MOH and CEO. This was language that was previously in the bylaw, and now it's been moved more appropriately into a policy. Delegation of duties. So 6.2.2, we did not have a policy related to this, nor was it really referenced in our previous bylaw. So this is something that is new to the board that we would not have seen before. And anywhere where we saw that there was a gap or something missing, we did borrow from other health units to see what they had and sort of mirrored their language. All of these policies and bylaws have been reviewed by our legal counsel. And as per our current bylaw, this would be just the first reading Then in October, we'll bring them back for that second reading. So don't panic, because I know it's a lot of words and a lot to read. Gives you time, obviously, to read, ask questions. If there's changes, those changes can be made. And then ultimately, they'll be brought forward in November and or a future board meeting, I suppose, for that final approval. One item that we've embedded into this bylaw as well is the signatory, so signing off on each bylaw, the date it's signed, and also embedding in there the date that it'll be brought back for review. And so currently it's 2 years for the bylaws, and then the policies will set at 1 year. So our whistleblowing policy, as you know, comes back every year. So some of those policies will come back more frequently for review. And they'll have a similar process of review, reading. If there's changes, then they'll be brought back to a next meeting for approval if there's any changes. So happy to answer any questions of us as it relates to the modifications of the policies and the bylaws. And obviously, I'll turn it back to the chair for just.
Perfect. Thanks, Nicole. So I'll open it up to questions. A lot of housekeeping here, so I'm not sure if there are any specific questions. If not, sorry, is that Mark? Mark, do you have your hand up?
Yes, I do.
Sorry, go ahead, Mark.
So the direction that administration has received on this predates my joining the board. I think from my prior experience, either being on the board or supporting the board, normally when there's something that is this large that is undertaken on behalf of the board, there's either an ad hoc committee that's struck for policy governance or a standing committee on policy governance. So not only dealing with creation, but also ongoing monitoring and fielding governance related questions as part of our regular monitoring processes as we operate as a board. So I guess what my question is, has this Board of Health ever considered striking a policy governance committee? And would that be helpful for the board to have more involvement in the creation of these, as well as the ongoing monitoring and streamlining of these processes over time? And if that is something that the board is interested in creating, because I'm more of a process-oriented person, I would be happy to volunteer myself for that, as well as a few other directors.
So, I mean, I'll start. In my time, it's just this one term. I don't think we've done that, or we've done it by committee. I believe there were other bylaws that were brought forward, I want to say 2 or so years ago. It's all kind of a blur, to be honest. And we were doing them sort of in pieces. So before that, I don't know if anybody else, if maybe either administration or some of the board members that have longer standing recall a time when it was done via committee, but it's a good suggestion. I know we've done it in other places or on other boards like that. So I don't know if administration has a comment, if any of the other board members would have comment. Nicole?
So I can add, just from an administrative perspective, and my colleagues can correct me if my memory doesn't serve me well, but at least as long as I've been here, which is about close to 9 years. They haven't been reviewed by committee. Our previous iteration of the bylaws, which we're adjusting now, were completely drawn by our legal counsel in collaboration with the executive committee. So I guess they were done by committee in that they were discussed and brought back and forth through the executive committee. And then ultimately it brought in pieces, as Reno mentioned, to the board, because they were so large, brought in pieces until then they were finally approved by the board in its entirety. Those haven't been reviewed, which is why we suggested obviously bringing them back. And there's a lot of modifications that needed to be made, that the board bylaws had not been reviewed since about 2017. So we were behind on the review. again, recognizing we were in a pandemic. So I think we had certainly other priorities in our minds, but they had been not reviewed in quite some time and needed definitely a large update. But that was the previous process. Before that, I couldn't speak to, but this last iteration and rehaul of the bylaws were done by legal counsel, brought back and forth with executive committee, and then finally brought to the board in the end.
So do we expect, seeing as with the election, with the new members coming on board in November, there will be a very specific onboarding process, aside from general sort of a simple orientation or things like that. Do we have a larger sort of review of either committees or those types of things? Because I'm thinking, Mark, that maybe this would be a good thing to defer to that orientation, to say if there was a committee that wanted to be struck with the new board and the new makeup, that it then be done at the beginning of the next term, so to speak, because it's then a 4-year term with the same board members. But I'm wondering, Nicole, if that's, does that happen with respect to any subcommittees or executive committees when we do the orientation with the new board?
So we would not direct committees of the board. We are updating the orientation. We are updating the orientation material, and we will organize individual orientation. Then we are thinking next round, a group orientation might be most beneficial. And it does cover, obviously, the bylaws are, on budget, Ontario standards, what it means to be part of a public health unit and govern a public health unit. There is board elections, as you all know, usually at the beginning of the year for the audit committee, our now project governance committee, which is an ad hoc committee that we have, as well as our executive committee. Certainly the board could add committees that is covered in the bylaws to say ad hoc committees could be added. But if there's interest of the board, obviously, to add other committees, such as an orientation committee or a bylaw review committee or a policy committee, that could be ad hoc or added into the bylaws and we'll make those adjustments and bring it back to the second reading in October. Only one point I will mention as well, we are working on a calendar that will have when certain things are brought forward, and that includes terms of reference for each of the committees, so when they need to be reviewed and when they'll be brought back to the board as well. And so we're trying to lay all those things out and time them well across the year, so that there's a good roadmap for the board members as well as administration on what routine items come when.
Okay, so maybe I'll look to Mark for maybe direction or what he's thinking, and maybe either to raise it at that point as part of potentially a new committee that would be formed at the start of that term, or did you want to explore it happen sooner?
So I would suggest that it happens sooner, just because I think you still have to develop terms of reference, you still have to look for individuals who are interested. It's timely with going into this second review of what's been prepared by administration and legal so far. So I think that there is some, this is kind of a bit of a jumping off opportunity for us to take a look at that. I think it's in keeping with good governance practice to have the board more firmly involved in policy governance and policy development. So I think if there's an opportunity to consider that today, that would be great. And if for the other directors this doesn't feel like the right timing and would rather wait a couple of months, then I'm open to that as well.
So I'm just looking for any other input from board members. Obviously, to strike and create a new committee, we would need a motion to guide us in that direction. So looking for any feedback from other committee members, if that's a direction they wanted to go to. if they felt that it might be more prudent to wait until basically November meeting to start that process. Just looking for any other guidance here. Any input, Tracy?
Thank you. I think for myself at this point, I'd like to wait till November. I think it's a good time that you'll have a new committee before you. Maybe a report can come back, because I think that Nicole, you were able to offer some history as to how things have been done, but maybe a report coming back that better guides the new committee that comes together might be good. But those are just my comments.
Well, and maybe that's the starting off point, the jumping off point, as far as looking for a report back to come to us at the beginning, which would, I guess, be November if possible, to outline what processes we've followed and what process we would need to create and then strike, and then which bylaws would have to be potentially changed. Does that make sense, Mark?
Yeah, that makes sense. I think, just as another observation, I find that this particular board really leans quite heavily on the executive to advance a lot of these different things. And I think that could also improve board engagement by diversifying a little bit of some of those roles and responsibilities.
Yeah, I mean, I'll speak for one of the executive. I would love to share the wealth of the wonderful work we do. So I guess can I say that that's the motion, Mark, that we ask for a report back outlining what has been the past practice and what a committee would look like going forward at the beginning of the next term of this committee. Does that make sense?
That makes sense to me.
Okay, so let's consider that a motion. Sorry, Nicole, do you have your hand up?
I don't know what's proper. If you call the motion first, or I think I have some clarification that might be needed on our part from administration, but I can wait till after. That's appropriate.
Okay, so that's the motion on the floor. Do we have a seconder for the motion? Joe. So moved by Mark, seconded by Joe. So we'll call the question to order. All those in favor? 1, 2, 3. Sorry, all those in favor? 1, 2. Okay, thank you. So that passes. Thank you. Nicole, did you want me to just sort of connect offline, or?
Yeah, I guess my clarification would be, so the motion is a report back, which was what our process was. That report back will be in November, which means the second reading will not happen for quite some time. So just want to be clear. So we're delaying bringing any of the bylaws and policies back so that we can bring a report to you that says how it's been done in the past. I mean, document what I've basically said, which is how it's done. And then I heard make suggestions. So are we making the suggestions in the report, or are we making those modifications directly in the bylaw? I guess I just want some clarity on, and I, through you, Mr. Chair, maybe that's to Mark or Tracy, who requested the report. I just want to make sure that we understand what the direction back to us.
Well, just first, let me ask, I was under the impression that we would move the second reading of the ones presented today, just because the process had been ongoing, but going forward to change it for any future work on bylaws. And so I see Mark nodding, I see Tracy nodding, the mover and seconder. So 6.21 through 7 will be, I'll get a motion right now to move those along. And then afterwards, going forward, a brief sort of history of what we've done, and then some options as to what a committee would look like from the new board.
Thank you. That's
okay.
very cool.
Thank you. So as so that passed. Thank you. So I'm just looking for a motion. We can combine all of 6.2 from point 1 to point 7 as we approve the second reading of those bylaws. Just looking for a mover, Mayor DiCarlo, seconded by Mark Ferrari. Anybody opposed to that motion as presented? Seeing none, all those pass. Thank you. So next is 7.0, which is the consent agenda, which has a few information reports. So the financial report, status indicator dashboard, health competency self-assessment report, the strategic plan, and the communications report. I note that there are names next to them. Are we looking for presentations of those, or are those just on consent and can be approved by the board?
So the strategic plan is listed as a recommendation report. So we will have a short presentation and then a resolution for the board to consider.
Okay. Can we go to that, or?
Yeah, and we actually do have presentations associated with 7.1 and 0.3, although I don't see them that they made it on. Yeah, they are on the agenda under new business as well. So the reports can be accepted, and then we'll go into the resolutions and new business where they'll be presented.
Okay, perfect. So can I get a motion for any questions on those items first? Sorry, I'm in a more of a hurry than I probably should be, but so no questions. Looking for a motion to receive 7.1.1 through 5, moved by Judy, seconded by Councillor Sleeman. Anybody opposed to that motion? Seeing none, that passes. Correspondence 7.2, the letters from Chatham-Kent Public Health, Sudbury and Districts Public Health, and Niagara Board of Health, so all for information. Either any questions on that, open it up. If not, direction to receive. Sorry, Nicole, did you have a comment?
I will just note 7.2.1, we are recommending to support Chatham-Kent's letter, as well as 7.2.2, we're also recommending the letter regarding healthy baby children. Right.
So 7.2.1 is support, same with 0.2, and just for information for 0.3. So could I get a motion to that effect, please? Moved by Joe, seconded by Aldo. Anybody opposed to those motions? Seeing none, that passes. Thank you. So resolutions, recommendations. So now we're at 8.1 with the renewed strategic plan. We'll go back to Nicole.
Thanks, everyone. So I will just introduce Mark, who I believe the board has met before. He is here as well. So Mark Fry is our Manager of Planning Strategic Initiatives. Obviously, we talked about our strategic plan and revising or refreshing our previous strategic plan from that ended in 2021 that we clearly didn't get to fully work on given a number of items, most particularly the COVID-19 pandemic. And so we had embarked on that process with you all, as well as, undertook a number of engagement with our community, staff, management, et cetera. And so you have in your package the draft, a strategic plan that is the result of all of that conversation. And I will turn it over to Mark, and I'll acknowledge Christy McBeth as well, who have really carried the torch to get this to the finish line, and, appreciate all their work on this. So Mark is just going to walk through the strategic plan for you, and then the recommendation resolution, certainly speaks to itself. We'd be looking for a resolution to adopt this as our current strategic plan, and then we'll move forward in creating the operational components of that plan. So, Mark, if you're there.
Yep, I'm here. Hi, everyone. Thanks, Nicole. I'm just going to share my screen here and just do a quick presentation about the strategic plan renewal process. So just a reminder, I know the board has been heavily involved in the process, but we're required by the Ontario Public Health Standards to produce and maintain a strategic plan. And the current plan under review was developed to address the post-pandemic challenges and opportunities that we are faced with. And you'll notice that it has a slightly shorter lifespan than we have used in the past. We've had 5-year strategic plans, but partly this was to address that acute need to have a plan in place post-pandemic, but also to give us leeway to develop a longer term plan after we've had some time to move on from the pandemic. And I'll mention too that this included a lot of consideration from our previous plan. As Nicole mentioned, we didn't get an opportunity to really live that previous plan to its life cycle. And so we've incorporated that, as well as you'll recall the 2022 renewal plan priorities that had been reviewed by the board. Those are taken into consideration in the development of this plan. And the process itself, again, many of you were intimately involved, so greatly appreciated that you were able to make time and provide feedback and support on the development of the plan. But it began with interviews with board members as well as the leadership team. We also had a survey that was conducted with local partner groups, and that was a sample size of 37. And there was a 2-day Board of Health meeting where aspects of the plan and direction from the board was discussed and incorporated then into the plan that you see today. We provided an opportunity for our management team to discuss and review the plan. And then an all-staff survey was distributed, and we had 104 responses. And the feedback from those responses were integrated into the version that you see today. As well, there was a subsequent survey that went out to the Board of Health to review the final content, and that feedback was incorporated into the version that you have in your board package. And so I'm not going to go through every aspect of the plan, but just some of the key highlights. I know you have it in your board package. I'll also show how it will be displayed on our website, but the vision has been changed to be healthy people in a healthy community. And the mission was altered slightly from our previous plan. It now reads, the Windsor-Essex County Health Unit promotes, protects, and improves health and well-being for all people in our community. Our values have not changed. They're still accountability, empowerment, leadership, collaboration, and equity. And the priorities that we're setting out have been altered, and to reflect again the unique nature of the post-pandemic environment, as well as the direction from our board and our partners as to the areas where we can focus our efforts in the next 3.5 or so years. So they include partnerships, advancing meaningful partnerships that focus on health equity and priority populations, organizational development, advancing operational excellence by increasing employee capacity and knowledge, and through continuous quality improvement efforts, and effective public health practice, advancing programs and services through evidence-informed decision-making, effective planning, and evaluation. And you'll note that there are specific objectives in the plan that we intend to focus on related to those priorities, and operational characteristics and reporting elements will be forthcoming as we live this plan over the coming years. And in the interest of keeping it brief, that's all I have prepared in terms of presentation, but I will point out our website content will be live shortly after the board meeting, and it will include this new update as well as the objectives under each of those priorities. Thanks, everyone.
Thank you. Open it up for questions. Judy?
Sorry, took me a minute to get off mute. Thank you very much. I just, I'm not sure if this is the right place to raise this, but in our strategic plan, we do reference equity as one of our values. In our board self-assessment, we talked about our low rating with respect to the board reflecting the population in Windsor and Essex County. And I'm just wondering, and perhaps it maybe is something we'd have more consideration under the operational plan, but I think that unless you're proactive in the area of diversity and inclusion, and I think Board of Health are a little bit limited, or our hands are tied because of the way the Board of Health members are assigned, but I think it's something that we need to look at for the makeup of the board of directors. So I don't know if that would be something that falls more under the operational plan, but it's likely something I'd like to see us have some focus on over the next few years.
So may I add? Sure. So it would certainly, you'll see equity, diversity, inclusion as part of some of the objectives, and that would be something that you would see as an element of an operational indicators or objectives. We have discussed this actually internally and with the board of the past. We are a little bit limited. However, our current bylaws and as well, not changed in the those that are being considered, do allow some consideration of outside members, so not provincial appointee and not elected official appointed to the board, to consider other members to be appointed to the board. And so that is also something that may be able to be considered, whether it's, Indigenous representation or, representation for other communities. And that's something that could be reported on the future. Other health do have that. So they're not an official, it just changes how they are a member of the board, but they are able to join the board, whether it's a youth representative or various communities within their, catchment area.
Okay, thank you. So that's something I'd like to see there. Thank you.
And I should add, sorry, just to Judy's point, maybe, and I think Mark touched on it, but once the strategic plan is approved, then obviously we would create operational objectives that are associated with the strategic plan, and those would be brought back for consideration as it moves forward, and then report that.
If there's no other questions, I'd make a motion to approve the strategic plan.
The proposed motion that's tabled in the report. Yes, Judy. Looking for a seconder to Judy's motion. Aldo, anybody opposed to the motion as presented with the proposed motion in the report? Seeing none, that passes. Thank you. So next up is the signing authority and officer resignation report. I don't know if Lori wanted to comment on this. It looks pretty straightforward, but.
No, I don't have any specific comments unless anyone has questions for me.
Open up for questions. If not, direction on this. Don't all jump at the same time. Can I get a mover and a seconder if we don't have questions, or we don't move by Tracy? Is there a seconder? Seconded by Mark. Anybody opposed to the motion as presented in the report? Seeing none, that passes. Thank you. Sorry, next is so moving on to section 9. So we dealt with item 9.1. Now move on to 9.2. There's a presentation for the Windsor-Essex HSI dashboard.
So I'll just introduce Ramsey D'Souza. Most of you would be familiar with Ramsey. He is the manager of our epidemiology and evaluation department. He's going to do a short presentation on our dashboard. So we have tried to consider, we are required to provide surveillance data. You have seen that mostly in the past and in our community needs assessment, which would be a static report. And we're trying to move towards something that's a little bit more interactive, updated a little more regularly where feasible and possible, and sort of takes a bit of the lessons that we learned through COVID. And I know our dashboard has been really something that's been valuable for us, but also our community members. So just turn it over to Ramsey. I think he's there, and he'll go through just wanted to provide the board an update on this.
Thank you, Nicole. I'm just going to share my screen quickly. Members of the board, thank you for having me here today. In terms of what we're looking to do, as Nicole mentioned, we embarked on an ambitious journey to reimagine how we would conduct our public health assessment and surveillance here at the health unit. We learned a lot of lessons during our time with COVID and wanted to apply those principles in terms of how we moved out of the pandemic into this new phase of the pandemic, where we're looking to do some of our routine work, but also keep in mind that there's still the pandemic happening in the background. As Nicole mentioned, prior to the pandemic, we primarily conducted large-scale reports on various topics, whether it was a community needs assessment, reports related to oral health, injuries, and so forth. These were well put together reports, but they were also time-consuming at the same time. From the conceptualization to the end product, it could take about 3 to 6 months, depending on the topic area, sometimes up to a year if it was a CNA. What we learned from COVID was the need to have timely data readily available to make informed decisions. Also, with the pandemic, we went about 2.5 years because of resource allocations and capacity to strictly working on COVID, and weren't able to properly dedicate some resources to conducting population health assessment and surveillance. Some of the solutions that COVID had taught us was to apply business intelligence principles, to use visualization to better communicate the data to our population, to our partners, and to other key stakeholders. So our goal is ambitious. We're looking to move away from static reporting and into more interactive reporting, using data visualizations and dashboards. The main goal of this is to have timely data and to also be able to update our data as frequently as we can with when the information becomes available. This can be 1 week at a time as it relates to topics like opioids, which we get routine data for, quarterly, annually, and as needed as the data becomes available to the health unit. The other big feature that we're hoping to work on is to also look to address data gaps. This allows, with the efficiency that we can publish these dashboards that are topic specific, it allows my team and the health unit to also be proactive in identifying data gaps that we see. How can we look to procure data, whether it's working with our partners that in a community that might have some of this data, whether it is something that we may do ourselves and collect that information in conjunction with our program areas, and use that data to help inform our plans and help inform our programs. So what we've done thus far is to look at some of our topic areas that we have data readily available. This is just a snippet of what our plans were for the next 6 to 12 months when we first started off. So some of which we've already completed, and some of which are currently in the works right now. Not all the topic areas are mentioned on this list. Part of that is due to also availability of data sources. There's some information, for example, from the CCHS that StatsCan has, where the information is a bit outdated. That speaks to primarily our health promotion and health behaviors and risk factors. That's not been included here, but it's something that we are looking for alternative ways to collect this information. So we've coined it WESI, which is Windsor-Essex Health Status Indicator. It's a web page that has a collection of dashboards that the public can now access. It's still a work in progress in terms of identifying new dashboards that we're looking to create, but it's a page where it will house all of our current and up-to-date information. I'm just going to provide a quick demo of that page. In terms of access, whether you're on the home page or any page at the Health Unit, our communications team has created a centralized feature of accessing that page. Under resources, if you click on data, it will bring you to our WeSci page. And we've grouped together our major topic areas into categories, from child and adolescent health to substance use to mental health, infectious disease. Some of the ones that we've created so far, I'll talk about. One of the key features is if you hover over some of the categories, it gives you a brief description of what is contained. It's not all-encompassing, but gives a highlight of what was proposed and what's currently featured here. For example, under infectious disease, when you click on the page, some pages will have the subcategories of what's contained. We're currently on our disease of public health significance, which we've converted into a report from a report into a dashboard, which provides yearly counts that and averages that we can look at, comparisons to the province, age and gender breakdowns as well, and it's done by disease. So, for example, if the end user was selected a specific disease, it also will tell the user what type of disease it is. So that way they have a better sense of what they're looking for and what they're looking at. Make it slightly bigger so it's easier for everyone to see. Additionally, we also are conducting monthly surveillance as well. Once again, if looking at a specific disease, we can look at month-over-month changes over time and how that compares to that specific month over the past 5 years. Anything over a 2 standard deviation is a signal for us that things are abnormal, and that we as a health unit and our infectious disease team, in conjunction with the epidemiology department, should further investigate. Alongside figures, we also have monthly counts that provide some insights to those that are interested in understanding a bit more of that specific disease topic. And lastly, as an example, if individuals really want to have a sense of what's really happening, they can get all of our diseases and their rates for that specific year, and also do a quick comparison as well. So, for example, if you want to know the highest rates, which one can sort by, in 2021, our STI, specifically chlamydia and gonorrhea, had the highest rates. But if you're only looking at specific diseases as well, you can filter down by the specific groups that will give the user some granular data that they might want to focus on if that's an area of interest. This was one of our dashboards that we looked at. Another one that we had put together was also under mental health, specifically as it relates to self-harm. And this looks at self-harm rates over time. The first section looks at a comparison with the province. However, if you're looking at sex-specific breakdowns, we have that as well over time, recognizing, for example, in this first figure that females both in the province and locally Windsor-Essex have the highest rates. We also have breakdowns by age, the types attributed to self-harm in terms of cause. And if individuals want to get a better sense of, for example, the age breakdown, and recognizing if there a difference between sexes as well, one can do that in this section. So, for example, if individuals want to know which sex is contributing to this increase, they can select the age group and get a better sense of what's happening. On top of looking at emergency department visits, we also have self-harm mortality data as well, which looks at the rates over time in comparison to the province, and the age groups also impacted here. One final example that I'll touch upon today will relate to our reproductive health. We also put together a dashboard on those specific indicators. There are a large grouping of indicators and also subcategories. So, for example, we have birth rates, but also multiple birth rates, preterm birth rates that one can look at. If anyone just want to look at maternal age, we have sub breakdowns in terms of what the age is for the province in terms of the average maternal age and the age over time, the age of mothers as over the past 10 years. The key feature of these dashboards is it's really efficient for us to make these updates. It actually gives us the team more time to explore newer ways of data collection, and in the end will give us timely data to help us inform our plans, whether it's annually and also our future direction in terms of where we want to go. So what are some next steps for the WESI? Part of what we also wanted to do was, with the introduction of the new census, incorporate that into our dashboard, have a really immersed way of looking at how what our population looks like in our community, working with our partners in the community to also procure some of the data as well, whether it's through data sharing agreements or working through collaborative initiatives to collect some of that information. We're in the process right now of collecting some of that data ourselves, as it relates to mental health, and also working through other partners to collect mental health related data in children and youth through our Ontario Student Drug Use and Health Survey with partners in Toronto and CAMH. And lastly, we also, as we talk about data that I've shown, we've done it at regional, at the local level as it relates to the entire region of Windsor-Essex. One ambitious project that we are looking towards and are currently working on is how can we break some of these key indicators into smaller geographical areas, so that way we can have targeted approaches to our work in our community, some of which may show some overlap across different program areas, whether it relates to chronic diseases or injuries or oral health, or show an overlap that there's a segment of our population in Windsor-Essex that's showing a high burden of disease across several indicators, which may generate some further conversations in terms of what we do collectively. This will allow for targeted interventions and targeted outreach as well, and with our population, and bring forth more engagement as we move forward. And with that, that's my presentation. Thank you for having me, and open to any questions.
Thank you. Looks fantastic, but I will open it up to committee members for questions. Just a quick one myself, or actually, Judy, go ahead.
Not a question. I just want to reiterate what you just said. I think it looks fantastic. I think that the more scientific data we can provide to people, I mean, it still frightens me or causes me great concern that we have 20% of people living in subsidized housing and 1 in 4 children living in poverty. So I think the more actual data we have to present to people, it helps arguments, it helps grants, those type of things. So I think this is excellent.
Thank you. Agree. My question, is there a public campaign, like a communications campaign, so that allowing or getting people to know about it, getting people to use it across the community?
Me to start?
Yes, I can start. So we wanted to have a soft launch here with the board. We are also working with our communications team after our Board of Health meeting to make that announcement and to have some more engagement across our platforms.
I'll also add to Ramsey's point. Ramsey's team's been working very hard to add on to this. It was one of our priorities that we identified in our early, in sort of our, what do we call it? The prioritization of renewal and prioritization plan. So we wanted to make sure that we had enough to be able to talk about. But we are also, Ramsey will also be presenting this to the OHT partnership table as well, recognizing that this, as Judy pointed out, it's valuable for the community, but certainly very valuable for our partners. I know we've received questions and notes from other, healthcare institutions or other service agencies that, are looking to do some of this work. And so knowing that they will have access to it, it certainly saves them time and it gives them the information they need as well to make their own plans. So that's something we feel would be really important. And the partnership table, represents for the Ontario Health team represents quite a number of partners, and so he'll be able to present the same information and ask questions. We also hope that that table is an opportunity, as Ramsey pointed out, if there are data sources that we don't currently have access to, it may be a potential to create some data sharing agreements and use our, Ramsey and his team's expertise to visualize that data and analyze it and make it more accessible and usable.
Great, thank you. I love being sort of the trusted resource in the community for good data and factual analysis. So any other questions from committee members? If not, direction. Just looking for, I believe, a motion to receive. Moved by Tracy, seconded by Aldo. Anybody opposed to the motion as presented? Seeing none. Thank you, Ramsey. Appreciate it. We'll move on to the Board of Health competency self-assessment. I think back to Mark. I don't see him on. Oh, there he is.
Yeah, I'm back.
Go ahead, Mark.
Hi again, everyone. Judy, I think you'll appreciate that your remarks actually show up in this assessment. So I was holding back commenting because you'll notice in the self-assessment that is a salient point about the board composition. So I'm going to be presenting the results of the board self-assessment. You also have that in your board package too, with some more detailed information, but just to give an overview, to reiterate that the purpose of this is to do a sort of get an idea of what the board's strengths are and areas of opportunity, both so that training and support can be provided for the board, but also we can assess if the board is improving or perceives themselves as improving in those areas over time, as well as to find areas of strength that can be leveraged for future actions by the board. This is also something that's required in the Ontario Public Health Standards. And I know you all filled out the survey, so you probably don't need me reminding you, but there are a series of questions that are divvied up into 12 competencies. And these competencies were identified and the questions were developed based on the Ontario Public Health Standards, our board bylaws, and the Alpha Board of Health Governance Toolkit. And these are the competency areas. I won't go into depth on any of these, but just so you know, these are the 12 areas that you were providing responses on and your self-assessment on. And a reminder that this was the scale that was used. It ranges from 0 to 4, and that 2, intermediate, and 3, advanced, are sort of target areas that we're trying to have a minimum baseline at that 2 on average across board member responses, and a 3 is our desired average score across board member responses. If we could ever get to a self-assessed 4, that would be great, but knowing that there's variability in everybody's knowledge, skills, abilities, and other attributes, that's probably not realistic with an average score. So these are our average scores from the 2022 assessment. You'll notice that leadership and governance is probably identified as the greatest strength. Most of our scores fall in that satisfactory or 2, that intermediate, to 3, that advanced range. But there were 2 that kind of are on the fringe or below that satisfactory range, and in particular, health equity and knowledge and delivery of public health programs and services. I'll also mention that legal and risk management were 2 areas that I think kind of are on the edge of whether or not we feel comfortable with those things as a board on average. And then there's questions about Board of Health operations. And for the most part, the questions are framed as a strongly agree to strongly disagree. For the most part, all of the attributes assessed, the board either agreed or strongly agreed with the actions. The one area I'll point out was the item, I feel the makeup of our board is reflective of the diversity of the Windsor-Essex community. And in that case, there is some disagreement about the board composition meeting that requirement. And so overall, taking into consideration also the qualitative responses that were provided by board members, some of the recommendations that came out were to provide training and education to the board, beginning in the areas where the scores were the lowest, so knowledge about and delivery of public health programs and services, health equity, as well as the legal and risk management components. It was also acknowledged by the board that through a number of responses that a return to in-person board meetings when practical would be beneficial for the deliberation and discussion process. And just to reiterate Judy's earlier comment, as well as the data that we've seen here, is that consideration of diversity should be given when selecting or appointing new Board of Health members so that it's reflective of the Windsor-Essex County community. And so again, you have the complete package, includes the report and the additional information, but that's just a quick synopsis of the results. Just occurred to me, did I share my screen? Or was I talking about slides that you couldn't see? I'm so sorry, everyone.
They're in
Someone should have told me.
The report's in the package, Mark. So I think everyone had that.
I felt like my screen was shared. Sorry, guys.
Is there questions of Mark at this time? Mark Furr.
Thank you. Yeah, I think, it's important for us to be able to do this probably again after we have new board members, after we get through the election, to see who's on the board and what those competencies look like so that we can compare this report to where we land and where we can expect to stay for the next 4 years or so. And it'll also be important to help us then inform board education as well as specific orientation strategies that we might want to have. So yeah, this is a great opportunity to reflect on that and possibly even to think about when we look at some of these competencies in terms of like even health equity, again, maybe revisit how we approach, how we query that. To make sure that we're really drawing that out. I know health equity is always a challenge with regard to boards because there's the do we reflect the community versus an acknowledgement that we don't have full control over who sits on the board, and so how can we overcome that through specific education rather than recruitment? So thank you for the report, and I think it's very interesting. Looking forward to refresh of it.
Nicole, did you have a comment?
Yeah, if I could just, so the board self-evaluation is a requirement every year to do yearly. So administration will be working on, as I said, a bit of a calendar of when things are brought back and to share with the executive committee and then back to the board. So we are looking at the timing of the next evaluation and self-assessment and for that information to inform education plans over the course of the year.
Thank you. Yeah, I think it's critically important. I think the last 4 years have shown how important it is for board members to not only understand the act, but also understand the end users, I guess, in some regards, or the residents that these decisions impact a lot more. So whether it be equity, late decisions, or other types of things, I think orientation and education of the board is a vital component when we regroup after the election and the board has a new formal list of new directors and members. I think it'll be critical at that time. So I think this will be a great report to inform a lot of that. So thank you. So just looking for a motion to receive at this time. Moved by Mark, seconded by Ed. Anybody opposed to that motion? And that passes. Thank you. I think last is the strategic plan presentation.
We already have addressed the strategic plan, so we're good.
Right. Okay. I just want to make sure that was the whole. That's it for the regular business item. Is there any other new business or anything to bring up? If not, I will look for a motion to move in camera at this point. Moved by Councillor Sleeman, seconded by Mayor DiCarlo. Anybody opposed? Seeing none. So we'll just take a minute to have everybody drop off the call who will not be joining us.